Hello everyone, this is about varicella zoster virus infections. The varicella zoster virus causes two distinct clinical syndromes. One is primary infection, also known as varicella or chickenpox. The other one is recurrent infection, also known as herpes zoster or shingles. The primary infection or chickenpox is extremely contagious infection. It is usually a benign infection of childhood and it is characterized by an exanthematous vesicular rash. The recurrent infection or herpes zoster occurs after reactivation of latent varicella zoster virus. It is most common after 6th decade of life. It presents as a dermatomal vesicular rash and it is usually associated with severe pain. Early in the 20th century, analysis of viral DNA from a patient with chickenpox who subsequently developed a herpes zoster verified the molecular identity of the two viruses responsible for these different clinical presentations. Chickenpox are the primary infection by varicella zoster virus. In this, the transmission of virus occurs via respiratory route, and then localized application of virus at presumably the nasopharynx leads to seeding of lymphatic or reticuloendothelial system. Then viremia occurs, and then diffuse vesicular skin rash appears. Ultimately, the vesicles either rupture and release their fluid containing virus or are gradually reabsorbed. Following viremia, active replication of varicella zoster virus in other organs can also occur, leading to CNS involvement, varicella pneumonia, myocarditis, corneal lesions, nephritis, arthritis, bleeding diathesis, acute glomerular nephritis, hepatitis, etc. Then perinatal varicella is when mother develops the disease 5 days before delivery or within 48 hours of delivery. The illness in this setting is unusually severe because the newborn does not receive protective transplacental antibodies and has an immature immune system. Then congenital varicella is where the newborn is born with limb hypoplasia, cicatricial skin lesions, and microcephaly. Herpes zoster or recurrent infection. In this, during the primary infection, the virus infects dorsal sensory root ganglion where it remains latent until reactivated. The mechanism of reactivation is unknown. Either the cranial or spinal sensory ganglion can be involved. It is characterized by a unilateral vesicular dermatomal eruption, often associated with severe pain. It is unilateral because the virus hides inside one dorsal root ganglion on one side of the body, and it is dermatomal because on reactivation the virus travels from the dorsal root ganglion to the skin along the sensory nerve fibers that come from that single ganglion. A single sensory nerve supplies a specific area of skin called a dermatome. It is painful because the virus causes inflammation and damage to the nerve fibers as it travels along the nerve to the skin. This nerve inflammation is what makes zoster much more painful than a simple skin rash. The T3 to L3 dermatomes are most frequently involved. When branches of trigeminal nerve are involved, lesions may appear on the face, in the mouth, in the eye, or on the tongue. Involvement of ophthalmic branch of trigeminal nerve causes eye lesions called zoster ophthalmicus. It can result in blindness in the absence of antiviral therapy. If sensory branch of facial nerve is involved, Ramsay-Hunt syndrome can occur. And it consists of pain and vesicles in external auditory canal, loss of taste sensation in anterior two-thirds of the tongue, and its lateral facial palsy. Post-herpetic neuralgia is where pain in the involved dermatome lasts for months after the resolution of cutaneous disease. In 40% of immunocompromised patients, cutaneous dissemination occurs, leading to increased risk of pneumonitis, meningoencephalitis, hepatitis, etc. And both chickenpox and herpes zoster are more severe in immunocompromised than in immunocompetent individuals. The treatment consists of, for chickenpox, it is to prevent secondary bacterial infection of the skin lesions, and there should be daily bathing, close cropping of fingernails, lukewarm water baths, and wet compressions are better than drying lotions for itching. The antiviral therapy is given in chickenpox of less than equal to 24 hours duration. For adolescents and adults, it consists of oral acyclovir 800 mg 5 times a day, or valacyclovir 1 gram 3 times a day, or famciclovir 250 mg 3 times a day. The average duration for this treatment is 5 to 7 days. And for children less than 12 years of age, the dose of acyclovir is 20 mg per kg 6 hourly. The treatment of herpes zoster consists of aluminum acetate soaks. And the mainstay of treatment is antiviral therapy, which consists of acyclovir 800 mg 5 times a day, or valacyclovir 1 gram 3 times a day, or for 5 to 7 days, or famciclovir 500 mg 3 times a day for 7 days. The duration of treatment with acyclovir is 7 to 10 days, and the later two drugs are preferred over acyclovir. Varicella pneumonia may need ventilatory support in most of the cases, and zoster ophthalmicus requires an ophthalmologist reference, and the medical management may require analgesics, atropine, antiviral therapy plus minus glucocorticoids. And then post-herpetic neuralgia is difficult to treat and might need analgesics, gabapentin, pregabalin, amitriptyline, lidocaine patches, fluphenazine or glucocorticoid. Thank you.